Well, greetings everyone, and welcome to the EKG case for the week of November 6th, 2011. And this is a case that kind of went wrong that I wanted to share with you all, and we can hopefully learn something from this mistake. So this is actually a patient that I had, not recently, it was a little while ago, and I've learned a lot since this case nearly burned me, and even worse, nearly ended up killing a patient. So anyway, 54-year-old woman came into the emergency department complaining of chest pressure, shortness of breath. She's got a history of breast cancer. She's tachycardic, tachypneic, pulse ox 94. And so, I don't even know why we need to discuss this case. This is so clearly a pulmonary embolism, right? No doubt at all, pulmonary embolism. In fact, I told the resident, this is so clearly pulmonary embolism, let's just go ahead and start the heparin now because she's got a little while to wait before she gets her CAT scan. We got an EKG on her, and it showed sinus tachycardia. Not much else I'm looking at there. And so the patient gets her heparin, and she's on heparin infusion. She's waiting for the CAT scan. Finally, the baseline EKG. We'll come back to that in a second. A couple hours later, she finally goes over for the CAT scan, and when she gets over there, she suddenly develops hypotension. She's diaphoretic. There's that overhead call. We need a doctor in CAT scan, so we go running over there, and sure enough, she's dropped her pressure to about 75, and she's sitting bolt upright, looking awful, like she's about to die. We quickly bring her back to the emergency department and recheck her EKG, and here is the repeat EKG. And now her diagnosis becomes very, very obvious. She's got practically no voltage at all, and now she's got this electrical alternans, which made the diagnosis very, very clear. She had a pericardial effusion from the beginning, and what we did to her was we put her into hemorrhagic tamponade. That's what I want to talk about just a little bit. Pericardial effusion. Now, this is a classic teaching that we all learn about pericardial effusion. There's this electrical alternans, tachycardia, low voltage, and cardiomegaly on X-ray, which is pretty common. It's very nonspecific. Just about everybody has a big heart on that portable X-ray that we get. Well, there's a couple of problems here with what our traditional teaching is. First of all, the electrical alternans that we learn, which is so classic and is always on the boards and always in the textbooks, is only present in about a third of patients at best. Less than 30% of patients will have electrical alternans. Now, tachycardia is pretty good, but yeah, take that with a grain of salt because if the patient's on a beta blocker or calcium channel blocker, you may not see it. Cardiomegaly, as I mentioned, is sensitive, but not very specific. What I want to focus your attention on here is just a very, very simple pearl. When you see this combination of tachycardia plus low voltage, always consider pericardial effusion. That's it. That's the whole teaching point from around for this. How do you define low voltage? My definition is pretty simple. And this is a little bit easier and more simple and probably more conservative than what you'll see in some of the textbooks, but I don't want to miss low voltage. I don't want to miss pericardial effusion, so I have a fairly generous definition for low voltage. I diagnose low voltage when I see that the QRS amplitudes in leads 1, 2, and 3, add them up. That includes all the way from the top of the R wave to the bottom of the S wave. Add it up, and if it's less than 15 millimeters, that's low voltage. Or take the amplitudes in leads V1, V2, V3, add those up, and if it's less than 30, you're looking at low voltage. Either one is fine. We'll go through some examples in just a second. Now, what's the differential diagnosis for pericardial effusion? Well, you can think of this in two ways. What's the differential diagnosis for low voltage? You can think of this in two ways. Number one, if the patient's heart can be thought of as a battery, if the battery is weak, you're going to have low voltage. So what kind of things make the battery weak? What kind of things make the heart impulse weak? Well, if you have infiltrative diseases, for example, amyloid or sarcoid, if you have end-stage cardiomyopathies or severe hypothyroidism, myxedema, you're going to have a weak battery. And then the other thing is that you'll have low voltage if there's something blocking the current from the battery out to the EKG leads. So something's getting in the way between the battery and the EKG leads. So if there's fluid in the lungs, in other words, a big pleural effusion or a big pericardial effusion blocking that current, or if the patient has a lot of soft tissue, a lot of fat, obesity, or if the patient has a big barrel chest like those COPD patients, then, and COPD also makes the heart weak in many of those patients. They have relatively low ejection fractions as well. Any of those things are going to give you low voltage on that 12 lead. Point, always think about pericardial effusion whenever the patient has this combination of low voltage plus tachycardia, especially if the patient's low voltage is new. Let's look at a couple of cases. So, unfortunately, I think this was another one of my cases back a number of years ago when I was at Mercy Hospital, community hospital here in Baltimore. 66-year-old man came into the emergency department complaining of shortness of breath for several days. Look at these cardiac risk factors. He's got a history of MI, cardiac arrest, tobacco use, end-stage renal disease. You know what? If this guy shows up in my emergency department just to visit someone, he's getting admitted. I don't care what his complaints are. With all those cardiac risk factors. Anyway, he comes in. He's hypertensive, tachypnic, a little bit tachycardic. He's got JVD and RALS. Chest X-ray shows marked cardiomegaly, no big surprise. Here's the 12-lead EKG. You'll notice that he's actually got pretty good voltage up here. I mean, these are big QRS complexes, but if you look at his inferior leads, he's got low voltage. Take the QRS complex in lead 1, lead 2, and lead 3. Add those voltages up. They add up to less than 15 millimeters. This is about 4 millimeters. That's about 4 or 5 millimeters. That's about 6 or 7 millimeters. That adds up to less than 15 millimeters. So he's got low voltage, even though the voltage looks pretty good out here. Remember, it's either one, either less than 15 millimeters in 1, 2, and 3, or less than 30 in V1, V2, V3. And by the way, take a look at his old EKG. Here it is. He's got pretty darn good voltage in those limb leads on his old EKG. The other thing that stuck out to me when I saw this case was his baseline EKG has flipped T waves out here. And now he's got what I called pseudonormalization of his T waves. So all the more reason that I was thinking this guy has acute coronary syndrome. So I pushed and pushed and pushed for this guy to be admitted. It was a busy day in the emergency department. Let's just get this guy upstairs as quick as possible. There's too many other people to see. Well, I called up the team, and I started this guy on aspirin and heparin, but the admitting team said, no, we're not taking him upstairs until we get an echo because we're not comfortable with his cardiomegaly. He's got such a big heart. I don't care about that pseudonormalization. And he had just, let me go back for a second. He had they were calling, is this a little ST segment elevation in the inferior leads? I didn't think that was anything at all, especially when you remember that the TP segment is your baseline. I wasn't concerned about that. They didn't know what to do with that. I didn't know what to do with that. So anyway, they insisted on getting a stat echo before they take him up there, and thankfully, we got the stat echo. So they saved this patient. They saved my butt also. They got a stat echo, and it showed near tamponade. That's how it was read. So quickly we stopped the heparin because we were probably going to end up inducing a hemorrhagic tamponade in this patient with a large pericardial effusion. And instead of admitting to medicine, this patient went off to CT surgery and fortunately ended up doing okay. But I didn't recognize that low voltage back then. Here's another case. This was fortunately not my case. Case 2, 42-year-old man that came in with chest pressure, shortness of breath, and cough. He said that he had been seen in the ED for cough and shortness of breath several days earlier and diagnosed with bronchitis, maybe put on some antibiotics. He's got a couple cardiac risk factors. His EKG now that he comes back with these symptoms, maybe some worsening symptoms, he's got low voltage, and what the physicians didn't really recognize is that he's got little hint of alternans in a couple of leads here. And they were instead, the physicians that were taking care of this guy were instead focused on the ST elevation. The computer read this as acute inferior wall STEMI, and the emergency physicians read this as acute inferior wall STEMI. The patient ended up being treated with heparin and thrombolytics. By the way, the formal interpretation by cardiology the next day was also acute inferior wall STEMI. The patient got thrombolytics. 2 hours later, had a cardiac arrest, PEA, and he ended up dying from a hemorrhagic tamponade. This guy had a big pericardial effusion, probably some pericarditis, which was causing the ST segment elevation, but people didn't notice the low voltage and just a little hint of that alternans. They were focused on the EKG interpretation, which called it an inferior STEMI. Patient got thrombolytics, hemorrhagic tamponade, dead. Unfortunate. Let me show you just a few more examples up here. Here's a 63-year-old man who presented with prostate cancer and shortness of breath. You know, cancer, short of breath. This is a PE, right? Start the heparin, but get the 12 lead EKG, and what you notice is there's low voltage in the limb leads. Add these up. They add up to less than 15. Also low voltage in the precordial leads. Add these QRS complexes up, V1, V2, V3. The amplitudes add up to less than 30 millimeters. So he's got low voltage by both criteria. So he ended up, instead of getting started on heparin for a PE, he went for a quick echo, and he was found to have a near impending tamponade that heparin would have certainly put him into full-blown hemorrhagic tamponade. And again, these patients with cancer oftentimes have metastases to the pericardium, which bleed and cause a pericardial effusion, hemorrhagic effusion. The last thing you want to do is put them on anticoagulants and turn that effusion into a hemorrhagic tamponade. Plain old normal pericarditis can also produce effusions, and if you anticoagulate those patients can turn into a hemorrhagic tamponade also. That's why it's so important to not call pericarditis ACS or PE, because the treatments, the drugs that we use for ACS and PE can potentially kill that pericarditis patient if the pericarditis patient has a big effusion. Here's another case, 46-year-old woman with breast cancer coming with shortness of breath. Cancer, shortness of breath, that's a PE, right? Well, think again. Get the quick 12-lead EKG, and she's got decent voltage in 1, 2, and 3, but out here, if you add these up, V1, V2, V3, add those up, they add up to less than 30 millimeters. She's got technically low voltage plus tachycardia, think pericardial effusion, and she ended up, we didn't have a bedside echo at the time, so she just went for a dry CT because it was the quickest test that we could get, and a dry CAT scan will show the big pericardial effusion, so you don't have to wait for that contrast. Just send her over for a dry CAT scan, and they'll pick up a big pericardial effusion. And she ended up being admitted to CT surgery to drain that pericardial effusion rather than being treated for pulmonary embolism. Here's another case, 36-year-old guy who comes in with HIV, with fever of 102 and a little bit of shortness of breath. He was an intravenous drug user also. So this is a slam dunk admission, right? He's HIV positive, IV drug user with the fever. What do? Send off 13 sets of blood cultures and admit him to medicine, right? Piece of cake diagnosis. So he's going to be admitted to medicine. He's got all these blood cultures pending. We can go ahead and start some antibiotics. But before he goes upstairs, we've got to get the so-called admission EKG. So here's his admission EKG, and what do you notice? He's got, I'm not really sure why he's got this right heart strain sign up here. It may have been just a misplaced lead. I don't want to focus on that. I want to focus instead on the fact that he's got tachy complexes in 1, 2, and 3. They add up to less than 15 millimeters. He's got tachycardia plus low voltage. So you know what? Before he goes upstairs, let's just do a quick bedside ultrasound. Here's his bedside ultrasound. He's got a huge pericardial effusion, which turned out to be a MRSA pericardial effusion. So instead of being admitted to med-ID medicine to just sit around and wait for his cultures to come back positive, right? If he had done that, he probably would have slowly developed tamponade and died. And as his blood pressure dropped, they probably would have thought he's getting septic, let's just broaden the antibiotics, right? Instead, because of this bedside ultrasound, because of his tachycardia plus low voltage on EKG, he ended up being admitted to CT surgery where they drained off that MRSA pericardial effusion. All right? And I think one more case, 55-year-old woman with shortness of breath who came in with some complaints of chest heaviness. Now, the low voltage that she's got up here, if you add these up, they add up to less than 30. If you add these up, they add up to less than 15. Nobody noticed that because she had just a little hint of ST elevation in a couple of the inferior leads, maybe out laterally. The computer called this acute inferior lateral STEMI. The emergency physician called this acute inferior lateral STEMI. Cardiology came down. They called this acute inferior lateral STEMI. In fact, here's the official interpretation, acute STEMI. So the patient goes to the cath lab. Patient got put on aspirin, and the patient got heparin, and the patient got a G2B3 inhibitor and went up to the cath lab, and on the cath lab table died of a hemorrhagic tamponade. And then they looked back at the original EKG and said, oh my God, this is not a STEMI, because if you take a closer look at some of these leads, what you notice is, remember, the baseline of the EKG is the TP segment. If you remember that the baseline of the EKG is the TP segment, you realize that there is no ST elevation. The ST segments are fairly isoelectric. It just looks like there's ST elevation because there's actually a little PR downsloping or depression, giving you the illusion of ST elevation. You can't call this a STEMI if there's no STE, right? If there's no ST elevation, it's not a STEMI. And in fact, what this was this was a patient that had sinus tachycardia with low voltage. What is that? That's a pericardial effusion until proven otherwise. A quick bedside echo could have saved this patient's life. Unfortunately, because everybody looked at those PR segments and didn't notice the low voltage, they and the computer mistakenly called this a STEMI, and the patient ended up being anticoagulated and died of a hemorrhagic tamponade. So again, really, really simple pearl for this week. Anytime you see the combination of low voltage plus tachycardia, especially when that low voltage is new, always assume you're looking at a big pericardial effusion and rule out that pericardial effusion before you put these patients on anticoagulants or G2B3 inhibitors or Plavix, or before you give that patient thrombolytics. Rule out pericardial effusion with low voltage plus tachycardia. So, simple takeaway point, some bad cases which helped us learn this. Don't let the bad cases be your teacher. Learn from our mistakes. That's it for this week. Hope that was helpful. Talk to you next week.